I'm going to turn the time off to you, Brad.
Thank you very much. I appreciate the opportunity to come and speak with you again. I'd love to ask, it's weird to lecture to a bunch of names. So if anyone feels like I require my staff to turn on their cameras. So if any of you feel like you can turn on your cameras, it'll probably be a more engaging presentation. I wouldn't mind getting to see your faces and being able to be able to talk and interact a little bit more. So thank you very much for giving that some consideration for me as a lecturer. Lecturing on Zoom has become a bit of a norm for all of us, but it certainly, as many of you are already aware, it's sometimes hard to feel as engaged, but I find that engagement on it does so much better when people actually share their videos. So we'll push forward that way. It's very nice to be able to see some of you this morning already. And I look forward to being able to share with you a little bit about the Burn Center experience. Today's focus is definitely on that of assessment and management of the burn patient. And one of the first things I love to share with people or ask them is, how many of you plan to be an ER nurse? Anybody? Interact with me. Okay. How many of you want to work in an ICU? How many of you want to take care of babies?
Me.
Quite a few. How many of you actually want to possibly work in a rural ER or take care of working in a nursing home? Something along those lines. So the reason I ask that is that there are a lot of moving parts to being a nurse. Anywhere that you can think of being a nurse has the potential for you to actually see a burn patient. That's why you getting a presentation on burn care is such an important thing for you to have in your wallet, in your back pocket, in your hip pocket, as far as what it means to be a nurse. We do hire new grads here in the Burn Center. If this is something that sparks an interest for you, I'm very diligent about the new grads that I do hire, because it's very overwhelming to work in an intensive care unit straight out of nursing school. If you have previous experience as a healthcare assistant, or if you've done your capstone, when you get to your capstone period, and remind me, what group am I lecturing to today? Where are you guys in school?
We're at Davis Tech.
Oh, I know you're at the DATC. I live in Layton, so it's always nothing like driving to the hospital right past your campus this morning to have to teach via Zoom. So stupid, right? Yeah, so PN2, tell me what that means, though. You guys know what that means. What does that mean?
Winter second semester.
RN school or LPN?
LPN.
So we got 2 semesters of RN left.
Okay. Thank you very much. I appreciate that. So it kind of gives me a little bit of an intake of kind of understanding where you guys are. So wherever if you end up doing a capstone in an intensive care unit, those are things that kind of lend me towards thinking about looking at hiring new grads, or if you have a lot of previous experience before nursing school in healthcare. Those are some things that give you a little bit of an intake, but it's still pretty hard to be able to do so. As you can see, a couple of different things here. If you guys are interested in finding me after, I'm pretty active on Twitter. I have my nursing one, Brad Wiggins RN, and I also am very active on the Burn Center, both on our Facebook and our Twitter account from a social media perspective. We also have an Instagram at that same account. Let me bounce out there and tell you guys a little bit about the Burn Center, if this will start working here. Let me see if I can get it to move. Slide, there we go. Finally moved in. You guys can see my slides okay, correct? Yep. Okay. Sounds good. So, nothing like showing you a hospital bed to a bunch of nursing students. They're like, yep, seen one of those. I get it. So I don't think this slide's like anything masterful, but it does kind of highlight a couple of things for you. We have a 15-bed intensive care unit. It is adult and pediatric. There's no burn center in the primary children's hospital. Burn care is a very unique specialty, and it's something that is very unique to our region as well. We are the only what's called verified burn center from Montana, Idaho, Wyoming, Utah, Nevada, as well as the kind of western slope of Colorado. So a pretty big area of coverage. It's the largest geographic area of any burn center in the United States. And where this says that we have an enclosed unit, what that means is that we have everything that we need to care for burn patients right here. We have our own operating room, we have our own outpatient clinic, and we have our own therapy staff, as well as our outpatient, education team that does a lot of outreach education. This is our clinic staff right there. We have a little 5-room clinic. This is our wound care center, as well as our operating room where we do surgical cases. We'll talk a little bit about skin grafting later, kind of show you what that looks like. This is our physical therapy suite, kind of shows you the need. This is someone's leg with a pretty extensive injury and why the importance of physical therapy is so needed. So again, I'm pretty open to questions, a pretty casual lecture. So if you have anything, just open them up and throw them in the chat over there. Happy to answer your questions for you and process that. Someone just put in there that someone's mic is kind of doing it. I'm going to mute a couple of people. I'm going to mute Olivia. There you go. As the person that's driving, I can mute a few people. So if we hear you, we're happy to mute you, but please just look for your feedback on that and help people to understand what that looks like. Our multidisciplinary team is obviously made up of a huge group of people. This is a listing of all of those, and I think that for the most part, I think everyone's aware of what multidisciplinary care means at this point. Probably the most unique thing about our system is that all of these people are assigned to the burn center. They're not bouncing around to multiple units throughout the hospital. It takes all of these people dedicated to the burn center to provide really holistic burn care. We'll talk a little bit more about that as we kind of roll through our team presentation here. These are some statistics for our burn center. Number of inpatients are 350 to 400 a year. Burns make up about 70% of those, and non-burns make up about 30%. Anybody have any idea what 30% non-burn injuries would come to a burn center? Bueller? Anyone got a guess? What makes up 30% of non-burn injuries to a burn center? Braden said skin diseases. Give me a little bit more. Road rash counts as a burn. Anybody else got another guess? Skin diseases is a little bit down the right path. Tell me a little bit more what that means, Braden. Okay, I'm not hearing anything back from that, but really overall skin diseases, maybe infections, really it's what's called necrotizing fasciitis or soft tissue injury. So I will show you some pictures of what that looks like, but burn centers are really, really, really talented at managing large wounds. We get a lot of wound closure well. We have to take out a lot of surgical interventions to necrotizing wounds, and then we skin graft those areas and get people better. I will show you some pictures of kind of a lot of burn injuries today, and I'm also going to show you some pictures of what it looks like from a non-burns point of view. Children make up about 33% to 40% annually. Out-of-state referrals are around 42%. We see right around 5,000 clinic visits in our outpatient center, and 71% of the time men are stupid. That's what this says. 71% of the time men are burned. I say that as a joke to each of you, but really that's kind of the national trend, and the biggest reason for that is that still across the United States, men are historically in more risk-taking jobs that present them for burn injury. That doesn't mean a woman can't do that job. It just means historically across the United States, that's what that looks like. So don't take me wrong out there on that. This is some statistics on our region. Each of the black dots represents where we received one burn in one particular year. Each of the red stars represents air transport teams around the region. Obviously, our med system for the University of Utah is our largest referral. They're the largest flight team within the state of Utah and have outgrown IHC's life flight system. So when you see the different helicopters flying around, just know that AirMed is the University of Utah's system with multiple fixed-wing aircraft, multiple helicopters, and referring patients from the entire region at this point. Kind of a state breakdown of the types of injuries that we see. You can see here that Utah represents about 60% of our patients. Idaho makes up about another 20%, and the rest of the states are kind of around, kind of within those areas of what I've shown you previously. And again, this changes from year to year and is not something you need to really stress about when you're looking at the big picture of stuff. Some of the things I like to highlight about our burn center is kind of the holistic regional approach to care. As a burn center, we view that it's our responsibility to try to keep people from getting burned. We don't want you to get burned. We want people to stay safe. For those of you that have lots of young children at home, we actually go into the elementaries, the junior highs, and the high schools and provide a lot of education. As those levels go up, the different types of presentations go up and what their caliber of expectations are, and be able to provide that. We do a lot of EMS education, so if any of you are EMS or firefighters out there, we do a lot of education with local fire departments and helping people to learn a little bit about what it means to be advanced burn life support trained. We offer classes regionally for lots of different referral hospitals as well as EMS. We educate the doctors, the nurses, and the EMS personnel in all those areas. We also have a burn-specific telemedicine program. We have an incredibly strong psychosocial follow-up care program, as you might guess is needed with burn care, and the impact that has on patients. And again, regional disaster support training is also something that becomes very important for us. Anyone know where this picture is from? This is the Brussels airport terrorist explosion. There were several people from Utah that were burned in this explosion. There were LDS missionaries that were there in the terminal when the bomb went off. We cared for 3 of those people here in our burn center. So our burn center tends to have a little bit more worldwide engagement than a lot of other burn centers because of Utah having so many different people that travel throughout the world for different types of things. It's quite often multiple times a year that we see admissions from some other location throughout the world to our burn center. These are all of our telemedicine locations, and this continuous map changes. I almost can't keep up with this map. This is probably from a year ago. There's more actual connections throughout Montana that are here, as well as some of the areas in Idaho, but you can see a pretty big area of coverage for us to be able to care. There's actually should be a dot all the way out here with Carson, Tahoe, right below the Tahoe area that we're also our referral area for also. So anyway, Utah covers a huge area. One of the things I'd like to highlight for you is the number of acute burn admissions that we see within a year. This little acronym right here, TBSA, stands for Total Burn Surface Area. So TBSA, something we're going to spend a lot of time talking about today. How much of your body is actually burned? Total burn surface area burn. Okay. One of the things this slide depicts is a lot of people think in a burn center we take care of gigantic burns all the time, people who burn their whole bodies. This is a slide from 2017, actually, that shows you that we really, 50% burns this particular year, we only took care of about 6 patients over a 50% cutaneous injury. I can tell you this year that's not the case. I'm actually taking care of about 15 to 20 large injuries. It varies from year to year, but one of the reasons I like to highlight this is that most patients who come to the burn center survive. They have some type of smaller burn size of their body, anywhere from half down, most commonly under 20%, and most commonly, even more so than that, is under the 10%, and you can see those stats. I think that's important as we kind of look through these slides today to kind of demonstrate to you how burn injury happens. About 60% of all of our patients come from flame injuries. That could be a house fire, leaning over a candle, fireworks, which has a double whammy in Utah in July. We have both fireworks, and if any of you were out there lighting fireworks in July, you know how epic of a year it was because of COVID. There were no large shows that were funded by cities, but there was plenty of large shows everywhere provided by the local community. Saw a lot of burn injuries from that. We see a lot of children. One of my highlights when it talks about flame injury or contact injury with fireworks related is that of sparklers. Anybody know how hot a sparkler burns? Everyone take a guess?
700 degrees.
Try again. Hotter.
1200.
Go hotter.
1900.
Close to 2,000 degrees, Mark. I appreciate you reaching out and saying that. Close to 2,000 degrees. And what I would say to you is that's as hot as a blowtorch. Would you hand your 3-year-old a running blowtorch? No, of course you wouldn't. But for some reason in the month of July, people hand off sparklers to their children like crazy. And they usually are very destructive. They can catch small dresses or clothes on fire, and they lead to very catastrophic outcomes, unfortunately, for a lot of children that we see. Scald injury is the next big challenge for pediatric patients. Our number one type of injury for our children under the age of 3 is scald injury. We see a lot of contact burns, meaning you've touched something hot. Most of you have had some type of contact burn in your life. A lot of people also come in contact with household chemicals, leading to chemical injury and electrical injury. We're going to highlight talking about all these areas today, as well as the soft tissue injury that we talked about. Everything you need to know on this lecture, you can learn from this slide. What do you think? Everything that's here is, and I say that kind of a little bit facetious to you, but the truth of the matter is that as you kind of apply this lecture to the rest of your nursing career, it really comes down to wound assessment. And if you keep this slide in mind when it comes to everything you're going to see for the rest of your nursing career, it really helps you to understand what the functionality and the challenges are of wound healing. Okay, that's the biggest issue when you have a large burn injury is, can they heal their wound? If not, we need to cut off that skin and we need to find skin from somewhere else in their body to do it. So where's a first-degree burn on this slide? Sunburn.
Epidermis.
It's the epidermis.
Yeah, it's going to be right across the epidermis here. Everybody in here's had some type of sunburn, and I'll show you a great picture of one here. This is one of my nurses, Scotty, who decided to walk across the Uintas without any sunscreen on his head, and this was not altered. You can see how bright red the top of his head is. As a bald man, I have been there and done stupid things like that. But we love putting one of our nurses there. But it's very superficial in damage. It is not calculated into total body surface area burn. So we don't count it as a burn percentage. We don't count it because it can heal on its own without any intervention from us and does quite well. You have local pain and swelling. Typically, you don't have any blisters. It's very spontaneous and healing. An example here is a sunburn. So this one right here always throws people off. Who's had blisters on their shoulders from the sun? Lots of people, right? So if we back up here for just a second, let's look at the slide again. Where would the blisters come from? And is the blisters indicative of having a second-degree burn? Don't be shy, all you people with your cameras off. What do you think? First-degree burns, epidermis.
The blisters formed from exudate, right? So wouldn't that have to be close to a blood vessel? So
blisters. So you're not necessarily thinking of that incorrectly. Blisters do form from exudate. Where would the exudate come from?
Dermis.
Well, yeah, but how do you get fluid in your blisters? Go back to what I think with Braden, was that you that spoke up?
Yeah, that was me.
Yeah. So when you say close to your vessels, tell me what that means.
So, I mean, I think it would have to be in the dermis area, right? Because the exudate is usually like fluid that is leaked out. I'm not sure if I'm explaining this right, but it's like leaked out of the blood vessels from one of the pressures, whether it's like pressure within the vessel or there's some kind of negative pressure outside of the vessel that draws it out.
Okay, so hold that thought for a second, Brad. I'm going to move forward to this slide here. Okay, so this is a child who was being held by mom while she was cooking with some grease, and the child flopped their hand into the hot grease. So this large fluid-filled blister, does that look like your blisters that you had on your shoulders?
No, that's huge. The ones you get on your shoulders are smaller.
So the reason I'm moving forward with this and wanted to show you this picture is hold that thought for a second. Let's go back to here for a second. So if it says here local pain and erythema, what is erythema?
Redness.
Redness and swelling.
Redness and swelling. So when you get swelling, like let's say you're running down the street and you twist your ankle, what happens to your ankle?
It swells up.
Why?
It's stiff.
Why?
You've damaged the tissue, the muscles, so then you've got some of that leakage, right, from the blood vessels.
Well, what's that really called? Like what makes it swell up? It's your inflammatory response is what I'm getting at. So when you have an inflammatory response, you get swelling. So if you go back to this slide, if I have an inflammation, if I burn my epidermis and it's pissed off, I actually haven't damaged the blood vessels. The body has shifted fluid there to help me with my inflammatory response. And when all the fluid gets there, it gets congested. And because the epithelial cells are a little bit damaged from the sun, it leaks fluid into those and causes little tiny fluid-filled blisters. But it is not a second-degree burn. Some people you might see in the hospital at this point as you start to care for people are some elderly people that have congestive heart failure or difficulty with their circulatory system. You start to see little fluid-filled blisters on their lower legs. Okay? The reason is congestion. The reason is inflammatory response and not being able to pump that fluid through. So if we go back to that picture of the grease with the little kid's hand burn, one of the things here is much larger filled fluid vessels. This is when the vessels are damaged. So if we go back to this slide again, we've burned it right down through the middle here. I don't know if you guys can see my mouse, but right down through, can you guys see my mouse moving across the screen?
Mm-hmm.
Okay, so right across the center here, across the dermal layer, is where a second-degree burn is. That's where your main vessels are. You have very few vessels across your epidermis here. Even when you get a small cut, you're cutting through the little small capillaries, but as you get down into here, you're cutting both capillaries and arterioles and really getting to start to see a little bit more blood flow, and you get a little bit more damage throughout here, which is what releases more fluid and makes you ultimately get to this part. This picture on the right is after we have debrided it. If you can take anything away from this lecture, I would love for you to take away this comment. When you see an injury, is it wet? If it's wet and it's all covered in fluid like this picture on the right, that usually means that it's got circulation. What else could you do to this to check to see if it had circulation? You have to touch it. So you got to push on it. And people are afraid of burn. If one of you ends up working in an emergency room, please don't ever be afraid to touch the burn tissue. People are usually hands off. They're like, oh, I'm not going to touch that. It's going to hurt. Well, that's actually part of the assessment of a burn injury. If I get to see this skin and we actually debride it and take it down and it's got actually good blood flow, I can touch this and see it blanch, right? It's got good blood flow. It's wet. It's most likely going to be a second-degree injury that's going to heal. If we go back to this slide again, first-degree burn through the epidermis, second-degree burn anywhere between the dermis and down to the bottom layer here. Anywhere towards the bottom of this dermal layer is considered a deep second-degree injury. Sometimes those don't heal well on elderly people, but most of the time on someone that's, like in this class as an example, most of you would probably still heal that up okay. But once you get down past that bottom layer right here into your subcutaneous fat, that's a third-degree burn, and the only way to fix that is with surgical intervention. Okay, so just kind of keep those things aware of you. Every time I show you a picture today, is it wet? Does it have circulation? How do I need to fix it and get wound closure is kind of our goal of this presentation. Okay, so again, secondary burn, what we call a partial thickness. Partial thickness means partially through the thickness of your skin. Okay, make sense? There's not, right? So here's a superficial second-degree injury. You can see here's another child's injury. This is actually from hot chocolate spilled down the chest of this little baby. It's really easy to have happen. For any of you who have small children, you can think of a time where you're probably holding your child. They were probably just in a diaper. Someone goes to do a cup of hot chocolate or coffee or tea or soup, and the next thing you know, the little child reaches up and grabs the cup really quickly and pulls it over. Is it wet? Is it pink? Do you think it blanches? Yeah, it looks superficial, and that's why I think it's important to be able to manage that. The child might lose a lot of fluid, might need an IV to be able to manage some of the fluid leaking, but overall this wound's going to heal and you're going to be able to look at it and know that. Let's look at some more pictures. So this starts to change our dynamic a little bit. So the injury on the left, what do you notice different about it? It looks wet, but what else do you notice about it?
It's not red.
Yeah, it's not red, so it's kind of white, and white is usually indicative of having a deeper injury, just so everyone's aware. So anytime I have more of a white wound, it's got a lot of exudate on it, and the dead tissue on there is referred to as a word called eschar, E-S-C-H-A-R. And eschar present usually means that there's a little bit of a deeper injury. Okay, it means it's all the dead skin cells. It is possible to kind of clean up the eschar with wound care, but this is a wound on the left that I would want to watch very well. It's lovely that it's a little wet, but we really need to pay attention to whether or not it progresses well. And I can tell you down on the tops of this gentleman's feet, they're actually a lot deeper, and it looks a little bit more kind of opaque and looks to be a little bit more yellowish, and those are some really significant areas. The picture on the right, we'll come back and talk a little bit more later about this. I have another image of it coming up, and I want to kind of talk a little bit about assessment in a few minutes. So this is another example. This is a gentleman that was in a house fire and crawled out and caught his back on fire, had different things that were falling across. You see a lot of areas of a lot of different things, and that's why I love to show you this slide, because I think it represents that cross-section very well. I don't know how well you guys can see it on your screens, but does everybody see these little tiny pink dots everywhere? Anybody know what those pink dots are? Take a guess. Anybody? Well, let's go back to our skin picture if you don't know. Let's go back and take a look. What could those little dots be? What are those little dots on top of here? What are these? What are those little dots right across here?
Like burned hair follicles?
Yeah, they're hair follicles. Why would a hair follicle be important for me in burn assessment, based off of everything I've taught you so far about this cross section?
Does that mean that like the burn could have extended down into the dermis, like through the hair follicle?
Yeah, it means that it's down into the dermis. But what else does it mean? If the hair follicles are gone, what does it mean?
So it probably was more of like a flash, right? Because it was enough to burn off the hair, but the skin around like the follicle didn't seem too damaged.
Yeah, so I'm actually good thinking, Braden. What I'm actually getting at here is that if I have a deep enough injury and the hair follicle's gone, then I know I have a 3rd-degree burn. It's going to be down past the base of the hair follicle. See that here? That's right at pretty much at the bottom of the dermal layer. So if hair follicles are intact, like they are in that picture, that's a really lovely thing for me to have a good idea that the wound is not all the way through all the layers of the tissue. Do you see hair follicles even in that junky stuff on your right? You see them all the way down there at the bottom of the picture? Bottom and to the far right. You see little dots everywhere? Right here, there's little tiny dots all over right here. There's little tiny dots throughout this whole surface. Even down here through all this, there's little tiny dots. And there's a lot of pink. And if I look up here, this is a really great indication to teach you a little bit more about skin. Where does new skin come from? Yeah, Kaylee just put out, I don't know if this is the right answer, but it's the same one. Hair follicles. I don't know if you were answering that question or not, Kylie, for me or not. But new skin generates from the base of your hair follicle, and it grows up the shaft of the hair follicle, and then it gets to the surface, and it covers. And you can see right through here, this whole little section right here is actually almost completely healed already on this gentleman. All the skin's been growing, it's been trying to heal, and that's going to happen everywhere you see one of these little red dots. So although this white tissue is a little bit deeper injury, overall this gentleman's back healed everywhere except for this lower portion right here. We've already cut off some of his skin here and done some skin grafting, and I'll show you that in a few minutes, what that looks like. But right through here, this is deep, kind of all the way down here. But for the most part, this gentleman's back is actually a deep 2nd-degree burn with a little bit of just basic secondary burn just through the epidermis up here, and this most of his back went on to heal. Okay, so pay attention to the hair follicles, pay attention if it's wet and what that looks like. Let's talk a little bit about the complications of 3rd-degree burns. Now, what do you notice different about these injuries? The discoloration, they're brown, right? What would make it be brown like this? Anybody? No circulation? Partially, yes. That's not exactly a bad statement. Necrosis? Yes. It's cooked. Yes, that is exactly right. That would be the layman term for it, is that this person burned for longer. Their tissue burned longer. So there is discoloration. If I was to zoom in on this, you'd actually see a lot of little brown spots all over this, besides these overarching brown spots. Kind of right through here is a good example. There's lots of little dots right here, kind of throughout that. What those are actually burned blood vessels. So when you see spots on that, it's very, very hard to appear in appearance. If you were to rub your hand across it, it would feel like a piece of leather. And guess what else is burned off? All the nerve endings. So if you get all the way down into subcutaneous tissue with a 3rd-degree injury, that's what's going on. This cut right here is called an escharotomy, and I will show you some videos of escharotomies in a few minutes of what that looks like. And we need to do those because it's... if you love hot dogs, I'm sorry, but it's kind of like a hot dog in a microwave. If it's cooked for a long time, it's too tight and the pressure builds up, and you can have a compartment pressure of your chest, you can have a compartment pressure of your legs or your arms, and ultimately that cuts off circulation and lends itself to having significant deterioration of circulation and can lead to amputation. So in this case, we have to do this over this, what we call a chest window, over the whole sternum area, because it's limiting the lungs' ability to extend and get full oxygenation. Okay, take a full breath. So in general, burns that are deep do not have any feeling. So someone will be like, oh, it feels fine, it doesn't hurt. That's a bad thing if you don't have any feeling in a burn injury. It's bad because it's dry and it's not wet. Okay, this is a person that was in a motor vehicle accident up here on the top picture, and the bottom picture is a small child that was sitting next to a campfire when gasoline was thrown onto the campfire. I'll move forward here. This is an example, again, highlighting a couple of different things. What's all this stuff here? Dead tissue, called eschar. This is eschar through here. This is eschar all the way up to here, as well as on his ear. Now, one of the interesting things I like to point out when I lecture is that anytime you burn soft tissue like this, or cartilage, where it has very limited blood flow, like your nose or your ears, they tend to not heal well, and most of this will shrivel up and fall off. If you ever see a burn patient in public, a lot of times they're missing their ears and they're missing parts of their nose if they've had a significant injury. Okay. All of this will need surgical intervention. You can see it's a second-degree injury around the edges and it's trying to heal itself, but again, most of this needs to be cut off and have a skin graft placed in it. Very extreme picture here to show you. This is a 4th-degree burn. Okay. These are typically lead to amputation. A lot of time are non-survivable. This gentleman on the left has a 4th-degree burn all the way up to his waist belt line. That's a very unsurvivable injury. These are the types of injuries you see when someone, unfortunately, is in a car fire and not able to get out and is on fire for quite a bit of time. All structures are burned, your blood vessels, your bone, your tendons, and muscles. The only alternative to treating this is surgical amputation, and this is a heck of an anatomy lesson for you. But they are some of the extremes. I don't see many of these each year, so I'm not trying to scare you, but I'm trying to demonstrate the different 1st, 2nd, 3rd, and 4th-degree burns of what it can actually look like. So it's very catastrophic injury, and again, most of the time leads to significant death. All right, so I told you I was going to bring back this hand picture. So this is Farmer Ted. He's out priming his carburetor on his tractor, and he burns himself, doesn't get any medical care. His family shows up and with Dad a couple of days later. He's very sick. He's throwing up. He doesn't feel good. He's got a fever. And this is what he shows his family. He's got this burn. He has this white stuff on there that's called Silvadene that another institution had put on him before they sent him to the burn center. This is before we actually debrided him, and this is after debridement. Okay. So based off of everything I've taught you so far, what section's going to heal? The right over here or the left? Which area looks less burned?
The right.
Right.
The right looks less burned. That's exactly right. But one of the tricks on this slide is this is really wet. This looks kind of a different wet, though. It doesn't look like that small child from the hot coffee injury that I showed you, right? What's different about it?
It's open.
Yeah, it's open. It's also it's kind of, really strong medical word here, snotty. It looks like it's just covered in snot. It looks real slimy, right? It just doesn't look like it's doing very well. And ultimately, this actually was a deeper injury here that was not going to heal and ultimately needed a skin graft. So pretty much this whole area down here was just, it hadn't been taken care of well for the last 5 days when he presented. All of this injury had already started to heal on his fingers. There might be a little bit of some deep injury right here where it's very white. But for the most part, and maybe a little bit on the top of these knuckles, but this is going to heal okay. This is going to need a skin graft. So it just kind of shows you, pay attention again. One of the things that I would do is I'd be touching this wound. This would not blanch. This would. So touch it, feel it, look at a wound. Just don't ever be afraid of a wound you guys see. No matter where you end up in nursing, you're likely to see some type of wound. Don't be afraid of the wound, okay? Dig in, check it out, touch it, feel it, prod it, look for pain, look for circulation, blanching, look for fluid, okay? And assess it. Let me show you a quick video clip here. I'm going to stop sharing this screen for just a second, and I'm going to pull up another video clip for you. Give me just a second here. Let's find the other video clip. Let's see. So I'm going to demonstrate to you guys right here. Get back to pausing. Get back to here. I'm going to share my screen with you here real quick again. Everybody see this video? You guys share my screen? You guys see my screen? Okay. All right, so this is a patient. You guys still hear me okay? My video was glitching out. This is a patient that was smoking while filling up his lawnmower with gasoline. This is what debridement looks like in the burn center. So this is done by nursing and the physicians at the bedside. This patient is on a ventilator and is so intubated and sedated. And this is pretty painful. A couple of things I want you to pay attention to. Is it bleeding? No. Is it red? A little bit. Is it blanching? No. Is there lots of fluid-filled blisters? No. The skin just kind of seems to be kind of a dark color. This is indicative of a flash injury. So gasoline burns really hot when it ignites. It flashes very quickly to high temperature, usually around 400 degrees. It burns areas very quickly, and you can see that we have to significantly debride this patient to get off all the kind of burned tissue. But this is what we do. A patient comes in off the helipad, picked up. We'll get them in here in the burn center. We'll get them stabilized as far as their system goes. And you can see he's got a few hair follicles, so it's probably a deeper second-degree injury for me if they're not all missing. But it just isn't blanching very well, and I can tell it's very deep, and ultimately he needed skin grafting. So, this is what we do in the burn center. Who thinks this looks cool?
It's pretty cool.
The peeling looks satisfying. Yes, I will tell you, as a burn nurses love to pop zits. If you're watching the zit videos, and we love to peel skin. It's a gross thing about burn care, but it's really something that you kind of get really talented at wound care, and you can see how much. We're basically peeling off all the epithelial cells, and we're peeling off about half of the dermis here. That's why it's coming off in chunks the way it is. All right, so let me get back to the presentation here for you. Gotta love the zoom bounce around, right? You guys can see the slides now, correct? Yes? You guys can see the diagram? Okay, just making sure. Sometimes it glitches out and grabs the hold of the wrong one. Also, my video was glitching out while I was showing you that video, so hopefully you guys can hear me okay. If we have any audio video stuff, please just put it in the chat and let me know, and I'm happy to repeat myself and let you know kind of what else is going on. So let's talk a little bit about the rule of nines. Let me back up. That was the video clip. The rule of nines is an important thing for you to learn how to assess a burn patient's burn injury size. The rule of nine exists for EMS personnel or people that have not taken care of burns very much, and it kind of breaks it into body sections of 9. So each of your arms is 9%, your chest is 18, your back is 18, each of your legs is 18 all the way around. So if you perfectly anatomically burn your right arm just on the front, right to the mid-axillary line, you would have what size of an injury? Just the front of your arm. 50% of your arm would be
4.5.
4.5.
Yep, 4.9%. That's exactly right. So one other really great feature for us with the rule of nines is that you can also use the palmar surface of your hand. Your hand on your body represents about 1% of your total body surface area burn. The thing that's nice about that is that if you ever see a burn patient, they usually don't perfectly burn their arm for you. When we have really large burns, yes, that's not a complicated thing. But if you have a sporadic burn injury, you can kind of use your hand very quickly to calculate TBSA and get a good situation going for you that way. And that's what this next slide kind of shows. Let's see. We'll come back to that. Anyway, I used to have a picture of the slide of the hand, but I just told you what that was. The other thing I want you to pay attention to on the babies is that babies' heads are larger. Their legs are smaller. And if you think about that, if you have any children at home, huge thing for you to consider. So someone with an adult male with a face burn might have a 4.5% face burn versus a child who could have a 9 or 10% total body surface area burn on their face. So big difference in the percentage of burn, difference in fluid requirements, and we'll talk about fluid management in a few minutes, but just something for you to consider what that looks like. Okay. In the burn center, we calculate these just a little bit more specific. This is a kind of an older picture I can show you. We like to color our burns in red and blue. Red is 3rd degree, blue is 2nd degree. And why would it be important for us to know what areas are 3rd degree? Anybody?
Those are the ones that definitely need the surgical intervention.
That is correct. Everywhere that's red, that skin has to be cut off, and only your skin on your body works. So if I have to cut off all of this red tissue, where am I going to get the skin?
Probably from the trunk and the front and the legs.
That is correct. And so that's where I have to remove the skin. Those are called donor sites. And by the time this patient leaves, they have a 53% total body surface area, 31% of it's third degree, 22% of it's second degree in this column. They're going to be close to 100% body involvement. Okay. So very important for you to consider. This gentleman was in a house fire again. You can see the makeup of their injuries. This is called a London Browder chart. It gets a little bit more specific based off of TBSA broken down to different areas of the body and allows us to be just a little bit more specific. So again, 53% of this gentleman's body is burned, 31% of it red and third degree, and we're going to have to cut off his good skin from his abdomen area and trunk, as well as his legs and the back of his legs to be able to get good coverage. Okay. All right, let's move ahead and talk about a little bit more of the meaty stuff of this lecture, and we're going to talk a little bit about what fluid resuscitation is. So back in the 1960s, there was a gentleman by the name of Charlie Baxter, who was a physician at at Parkland Hospital in Dallas, Texas, and he was a renal physician. And he kept getting consulted by the burn doctors, the surgeons, who said, we don't know what's going on with these patients. They're constantly in renal failure. Why would someone be in renal failure? So he kind of looked at it and tried to figure out what was going on with these injuries. These were healthy people that all of a sudden had renal failure. The number one reason someone that's healthy that might get renal failure is because they don't have enough fluid for their kidneys to use, and they ultimately kind of are not functioning and shut down. So if you don't have fluid, your kidneys won't function. So the idea behind it is that he was like, you guys aren't giving these patients enough fluid. And they were like, well, look at them. They're completely swollen. They're leaking fluid everywhere. They don't look like they need more fluid. But in the big picture, they actually did. They didn't have vasculature. They didn't have fluid in their vascular tissues or in their vessels, which is really kind of where it comes from. So who gets fluid resuscitated? Any burn greater than 10% total body surface area burn, any type of inhalation injury, because we can't calculate their burn size when you burn your lungs, any type of trauma patient, and most electrical burns all need extra fluid. So he created something called the Parkland formula. And he named it after the hospital instead of after himself. I think that tells a lot about what kind of a doctor he was. And I think that's an awesome thing. But in general terms, the Parkland formula says 2 to 4 mils per total body surface area burn times the percentage in weight. So I would like to run through a calculation. If you guys have your computer or you have your phone or your piece of paper there, I would like us to do a presentation, or I'd like us to do a calculation on this patient, and we're going to go with 4. It says 2 to 4. We're going to pick 4 mils, and we're going to say that the patient's total body surface area burn was 50. Do not use it as a percentage. So we're going to go 4 times 50, and we're going to say the patient's weight is 100 kgs. Anybody give me that calculation? 4 times 50 times the patient weight, which is 100 kgs. Someone give me a number.
I got 20,000
That is correct. 20,000 what?
mLs.
That's correct. And so people are like, 20,000 mils? Are you crazy? No, I'm not crazy. So let's talk about this calculation. According to the Parkland formula, someone that has a 50% burn and weighs 100 kgs would need approximately 20,000 mils of fluid. That's 20 liters of fluid within the first 24 hours. According to the formula, half of that is going to be given within the first 8 hours. Half of that would be 10,000 mils, and then we're going to divide that over 8. That comes out to 1,250 mils an hour of fluid. Kind of crazy. That's the volume of fluid that we have to give our patients here. Fluid volume management is incredibly complicated with burn patients. If you can think of a burn patient as a bucket with holes in it, that's how I'd like you to consider it. And it's your job to figure out how to keep the bucket full. It runs out very quickly. It causes a lot of ultimate huge problems, and life sustainability and hypovolemic shock compete with themselves, and we have to pour in the fluid. So I'm not kidding. 1,250 mils an hour is just a starting point for us to look to see how much fluid someone might need, and it's an extreme part of the burn center. These are all, we have kind of a nurse-driven protocol for fluid management replacement that is written by the physicians but guided by the nurses. And it works very well for us to be able to care for them. The most amount of fluid I've given anyone in a 12-hour shift was 38 liters of fluid in one 12-hour nursing shift. Okay, pretty crazy amount. We'll come back to this and talk a little bit more about it. Just understand, burn patients need a lot of fluid, and it's per percentage of burn. per their weight. Okay. Why do we give lactated ringers instead of normal saline? Well, the answer is on this slide. Some things for you to consider is that your extracellular fluid, your body right now is made up of sodium, potassium, chloride, and lactic acid. Okay, all of these different things here. Lactated ringers fluid most closely resembles all of those areas and allows you to be a little bit more healthy with that. Kind of helps keep the bucket a little bit more full. If I give 20 liters of normal saline, what's going to happen to your sodium? What's your normal sodium? Anybody know?
It's like 135 to 145, I think.
Yep, 135 to 145 is exactly right. So if I give you 20 liters of sodium that has 154 in it, what's going to happen to your sodium?
It's going to go up and you're going to retain fluid.
That's correct. And what happens with a sodium above 160? Anybody know? You can have significant neurological damage. Okay, so anything above 160 is a really danger zone. Anything above 150 gets your attention. Anything above 160 has significant consequences for the patient's neurological capabilities. You can give long-term brain damage that way. Okay, so pay attention to it. It's okay for someone to get some normal saline 1 or 2 liters at the beginning of their burn injury, but we want to get them changed over to lactated ringers as quickly as possible because, again, it most closely resembles, and you're trying to keep the bucket full that is on its way empty. Where are the holes in the bucket? When I say think of a patient as a burn patient with holes in it, where are the holes from the bucket? Back to your lecture on the wound section here I gave you this morning. Where are the holes? Talked about it. What's burned in your... If you get a secondary burn, what's burned?
The hair follicles.
No, the hair follicles are burned, yes, but what's actually burned down in the tissue? Your vessels, right? That's where the liquid's coming from, right? So if you've burned your cutaneous tissue 50%, then you're going to have a lot of leaking, and those are the holes in the bucket, okay? Go back to your ankle swelling. Why did your ankle swell?
Inflammatory response.
And inflammatory response means it's bringing fluid there. What happens to your ankle? It swells, right? Why doesn't the fluid leak out?
Because the skin's still intact, but with a
Bingo.
burn you wouldn't have that. It would leak out all the way because
Bingo.
there's no barrier.
Great job, Braden. That's exactly correct. Okay, so you got to keep the bucket full. Okay, massive inflammatory response. Keep that in the back of your head. Think about a burn patient again. 50% of my body's burned. It's going to do exactly what your ankle does when you twist it. Okay, very basic science, very basic pathophysiology. You have an inflammatory response that's massive. You're going to lose fluid, and you're going to be in shock. So, how do we know we're giving enough fluid? Well, you're going to make urine. We talked about that. Dr. Baxter said if you're giving enough fluid, you're not going to go into renal failure. So what do we like to see? For adults, we like to see 30 to 50 mils an hour. Children, 1 mil per kg per hour. And then here comes a really interesting twist. The most complicated patient I take care of in the burn center is that of an electrical patient. Linemen, people like that get shocked. You guys live up north like I do, most of you anyway. I don't know if you guys saw, but a power line fell across Highway 89 over the weekend. Did you guys see that right at Crestwood there? Right up above Kaysville and kind of on the Kaysville-Layton border. All that construction in 89, somehow a power line hit the ground and 89 was closed for a couple of hours while they worked on that. Luckily, no one had an electrical injury from that, but one of the complications that comes from electrical injury, don't ever touch a down wire, particularly when you think about all the windstorms we've had as of late, really creates the most catastrophic injury you can have. You lose extremities, those types of things. But the other additional problem is you burned internally, and there's no way for us to measure that. So we actually require 75 to 100 mils per hour of urine output. If on a normal burn, when we did that calculation, you came up with 1,250 mils an hour, that was giving us the 30 to 50 mils an hour of urine. How do I get 75 to 100?
You give them more fluid?
You do, Kylie. You have to, and in this case, if I want double this, I usually have to double the fluid. So that person that needed 1,250, if that gentleman had an electrical injury, he's most likely going to need about 2,400 mils an hour of fluid to be able to try to survive this injury. Okay, really huge fluid, huge complications. How much, anybody know or remember how much cardiac output you have? How many liters of cardiac output do you have an hour? Or a minute, actually? Usually 4 to 6 liters a minute, okay? So be thinking about how much you're cranking out, and if you're replacing that, it's really complicated for your cardiovascular system to manage that. Okay.
I have a question, and maybe you don't know the answer to this, but in one of our lectures, we learned that kids who are on chemotherapy, you want 2 to 3 mils per kilogram per hour of output. And so with this one, it's saying with the electrical injury, you want 2 mils per kilogram per hour. Like, is that related at all? Is it because of like is it because of the meds they're taking? I don't know. Like,
yeah. So what is chemotherapy? Why would you need more fluid in chemotherapy?
they are more acidic, like methotrexate is lowering their pH.
Yep. And what else does chemotherapy do inside the vessels? What's it trying to do? What's it kill?
Everything.
It kills cells, right? So you have a lot of damaged cells floating around your vascular system.
Okay.
As well. So when you give chemotherapy, you have to give it with more fluid because you usually find that it has a lot. You're getting a lot of products that your kidneys are going to need help filtering out. That make sense?
Yes. Thank you.
Yep. So other things that you guys probably haven't learned about since your LPNs is just kind of measuring your CVP. That's done with the central line, stands for central venous pressure. And then, things that we're assessing in the burn center is, do they have appropriate touch? Can they feel? How's their blood pressure and their heart rate doing? And all people that go through any type of trauma have a fluid shift that causes you to be in sepsis, or causes you to be in hypovolemic shock. Sorry, not sepsis. Causes you to be in shock, and usually that diverts fluid away from your intestines, and it causes something called an ileus. So an ileus is stopping of your bowels, and that usually lasts for about 24 hours. So we kind of trick the body by trying to put a feeding tube in and starting very small amount of what's called tropic feeds at 5 to 10 mils an hour to kind of start teasing the bowel and your body to be like, hey, I need to give some fluid over here where I'm trying to eat. So if there's anything that I've taught you so far this morning, it's that the burn injury has a large system impact. It impacts your respiratory, your cardiovascular, neurological, your skin, your digestive, and your excretory systems. It really is a major, major catastrophic type of thing to have happen to your body. Remember, your skin is the largest organ of your body. The general public does not realize that. If you ask someone in the general public, what's your largest organ, they're going to say the liver, the heart, or the brain. That's what they're going to say. Okay, that's just the general kind of philosophy. But your skin really is the largest organ. It is connected to everything. When you damage 50% of your body's largest organ, you have catastrophic system-wide impact. That's the way to think about the burn injury. Let's focus a little bit on respiratory injury. Focus a little bit about kind of those types of issues. Type of airway injuries you can have. You can have an airway injury that's up here in your upper airway, or you can have it below your airway. So carbon monoxide is the most common type of injury that we have. Signs and symptoms can vary and should be paid attention to. Injury above the glottis, singed nasal hair, facial burn, carbonaceous sputum. What do you think happens to people who have carbon monoxide poisoning? What would be a sign of carbon monoxide poisoning? Have any firefighters in the room?
Hypoxia.
Yeah, hypoxia, which usually
They turn blue.
Yeah, and so they're usually unconscious also, right?
Yeah.
Yeah, so you're unconscious. Carbon monoxide poisoning, burn injury does not make you unconscious. Being burned does not make you unconscious. You come across a burn patient that's unconscious, something else is wrong. They were most likely in a house fire, or they were electrocuted and they had some type of their heart stopped from the electrical injury, or they were in some other type of injury that's happened. Okay, so things to assess. Burn injury does not make you unconscious. Injury above the glottis, singed nasal hair, facial burn, carbonaceous sputum. If you're working in an emergency room or you're a first-line provider, you see someone who's got a burned face, one of the first things I want to see is their tongue. Stick out your tongue. They stick their tongue out and it's black and they have carbonaceous sputum all over in their mouth. That's indicative of someone who's had an inhalation injury, and those are people that are most likely going to be intubated. A good example of this is a small child who scalds the front of their face. A lot of people see a small child with the front of their face burned, or an adult, they freak out. They're like, oh, this patient needs to be put on a breathing machine. They need a ventilator right now. They need to be intubated endotracheally and have that. There's nothing wrong with their airway. Their cutaneous injuries burned here. You have to watch for swelling, but it's very normal for you to look like you went 10 rounds with Rocky Balboa and your hands, your face is all swollen, but your airway is completely attacked and you're able to move air. So we're very delicate and educate a lot about when it's the proper thing to intubate someone. I'm going to intubate someone if they have carbonaceous sputum, and you go to ask them, you're like, hey, Frank, how are you breathing? I'm fine. I feel good. Can you breathe? Yeah, I'm breathing just fine. No problem. That's just not normal, right? So you have to be able to think about who you're assessing, talk to patients, assess the injuries, and really dive in a little bit more so that you have a good sense of what's going on with them. Injury below the glottis, it's very difficult to see, and we have to use a machine called a bronchoscopy to be able to look down into the lungs to see what kind of damage is there. Sometimes that doesn't show itself for 24 to 48 hours for us, but it's something for us to pay attention to. As you might guess, if you burn your lungs, you're going to get the same type of swelling that you get from twisting your ankle. You're having an inflammatory response in your lungs. What would be bad about an inflammatory response in your lungs?
Could fluid be pushed into the lungs from that?
That's correct. And then what happens when you have fluid in your lungs?
They're definitely not working properly.
That's right. You're not getting good gas exchange. You're not getting enough oxygen. So we have to put people on a ventilator in that means, and we have to make sure that we're taking good care of them that way and forcing that oxygen exchange that a ventilator's job is required to do. So let's talk a little bit about the cardiovascular hit that your body takes when it comes to dealing with burn injury. Let's talk about a kind of cardiovascular system. This is actually a screenshot from one of my rooms where I had a brand new admission. This is an adult male, 25 years of age. He has a heart rate of 148. What's wrong with that?
It's way too high.
Why would it be high?
Body's trying to compensate for fluid loss.
That's potential, yes. Why else? That's
Just
one.
Stimulation. I mean, they just went through a traumatic experience.
So pain.
So yeah.
Do they have like too much CO2 in their systems? They're trying to like breathe it all out?
It's possible that you could have some tachycardia from too much CO2.
Or not breathe it all out,
Too much
sorry.
CO2 usually makes you somnolent. The more likely situation here is fluid volume. If your heart doesn't have enough fluid volume, it's going to pound away. So if you're managing pain and it's not going down and you have a low blood pressure right here, so this blood pressure is 90/53, a burn patient with a blood pressure of about 90/60 is usually their bucket is almost empty. They have a high heart rate, their blood pressure is low, and this is another thing you guys probably haven't learned about, but we mentioned CVP a few minutes ago. CVP of a burn patient, that's your central venous pressure. Anything this low, each of us right now is kind of 2 to 4, just hanging out at home, sitting around, listening to a lecture. But it can go as much as high as 6 when you're out working out and you need a lot of fluid, things like that. For the most part, we kind of sit at 2 to 4. I need to burn patients with fluid volume with that bucket that's trying to empty itself around 20. So they're really fluid low. They're getting plenty of oxygen this way. But this is a really typical type of response. The bucket's almost empty. I've got to fill it with fluid. As soon as I fill it with fluid, the heart rate's going to come down, and they're going to be in a much different situation. So if I look at this, is cardiac output up or down?
Down.
Cardiac output, your heart's pumping away. Is it up or down? It's going to be down, right? You're not pushing much out because the bucket's almost empty. Blood pressure, up or down? In this case, looking at this slide, we know that it's down. We need to raise it up. Urine output, up or down when it comes to low blood pressure?
Probably down.
Down because your kidneys are not getting enough fluid and the circulation is not getting there, so you have urine output decreased. Heart rate, we know we already answered that. It's up because your body's working so hard and it's metabolically stressed. And this is a little bit of a trick question for you as an LPN to think about. Vasoconstriction. Your body's vasoconstriction means it's clamping down your vessels, up or down?
I think it's going to be down.
It's going to be up because that's part of the compensation.
That is correct.
Okay.
It's compensating for itself, and it's trying to get blood back to the heart because you don't have enough, so it's clamped down. So your goal here is to decrease heart rate, increase blood pressure, increase urine output, decrease heart rate, decrease vasoconstriction by giving fluid. Fluid management's the key to the puzzle here. Figuring out how to get as much of that lactated ringers in there to be able to help the cardiovascular system to calm down and compensate and get good urine output. Okay, hypermetabolic rate is incredibly high. It burns over 30%. Sometimes it lasts for as much as 2 years after post-burn injury, and it's not unheard of for us to have to give a drug called propranolol to slow people's heart rate down and their metabolic rate. Okay. Edema is confined to a burn area in minor burns. Its response is systematic with that of over 30% or total body surface area burn, leads to a lot of edema or third spacing. Fluid resuscitation doesn't make it work, and it's at its peak in 48 to 72 hours. These can have dramatic effects for the patients in their face and their neck injuries in just a few hours. Let me show you a picture of what that looks like. This is an example of somebody with swelling. This is on admission, and this is about 6 hours later. You can see the size of the lips. You can see how complicated that is, and really leads to a lot of complication. When you have this type of injury, assessing that airway is very important because there's no way to stick a tube down here to get an effective airway. If you miss intubating this patient, you're going to have to give them a tracheostomy or an emergency cricoidotomy, which is when this tube has to go directly into the trach. Okay. So let's talk a little bit about compartment syndrome. We talked a little bit about it earlier. This person has their whole chest burned. It is circumferentially around their back. You can see it's circumferential around their arms as well. You no longer have peripheral pulses, numbness or tingling, loss of sensation. You have cyanosis and a lot of throbbing pain. Basically, it would be very difficult for you to be able to ventilate this patient. So I'm going to stop my slides again. I'm going to show you another video here for just a second.
Can I ask a quick question?
Of course.
How often do burn patients end up with a trach, like if they can't be intubated? Is that pretty common or not really?
It is common so one of the things we work on is that emergently it's very rare, maybe a handful of times a year for me. To be able to see a patient get ultimately a trach, but burn patients are usually intubated for a long time. If a patient's going to be intubated over about 3 weeks, we will go ahead and give them a trach because it's easier to manage their lungs and easier for us to kind of free up. It's more comfortable for the patient. So we do a lot of trachs here, but it's really kind of patient dependent. It's very rare to see them from the scene flight. If things were managed correctly, they should not need a tracheostomy before getting here. That swelling usually happens within the first 4 to 6 hours. We usually have time to manage that, and we can assess that airway pretty rapidly. We do a lot of telemedicine. We can do acute video conferences with another healthcare facility, and we can also do a lot of picture exchanges through a HIPAA safe app for us called the Burn MedPick app that allows us to see the patient ahead of time and give a lot of medical advice that way.
Oh, okay. Awesome. Thank you.
Yep. Let me share this next video with you real quick, and we will get rolling. This is a patient with a cutaneous injury wrapped around their chest. This is what's going to happen when we have to do that escharotomy at the bedside. So this patient's been admitted. We're having difficulty ventilating them, and this is what that looks like. So we're cutting through the eschar here. Okay, we're releasing the pressure. You can see how much tightness there is when we go to do that. We're using an electrical cautery machine called a Bovie so that it cauterizes the blood vessels as we go. You can see it's like the hot dog in the microwave effect. We have to open it all the way up. We'll go back and we'll touch up the bleeders where they are and be able to do that. It looks very cavernous, kind of looks like we just opened up the Grand Canyon. That is not necessarily the case, but it certainly looks that way when we get ready to have to do that. So let me find and go back to the lecture. You guys see my screen again, correct?
Yes.
So as you can see, we had to cut large, like this is what that video, this is actually the gentleman I was videoing, just to kind of show you what that looks like. 90% burn, motor vehicle accident, and you can see we're doing another one on the other side. This is the only way for us to ventilate the patient, you guys, and this is something that, again, it's referred to as an escharotomy because you're cutting through the eschar. If you cut down past this tissue, plus past your fat and subcutaneous tissue, you get to the layer of your muscle called the fascia. It's the covering over your muscle, and that's called a fasciotomy, and that's to go deep enough to release. We usually have to do those on someone's calf. If you think about how large your calf muscles are, when we go to cut escharotomies, a lot of time the muscle will poke out, and we'll end up having a fasciotomy in those areas. One of the other problems here is that we haven't talked about is when you have a third-degree burn that requires this, the tissue is not leaking. It's very dry. So think about the bucket not having holes in it, and then all of a sudden, what do I do to the bucket if I cut this hole in it?
You've created another hole.
I create a huge hole, and the body actually reacts to that and floods that area, and the fluid leaks out very quickly. You can actually kill your patient with hypovolemic shock at this point. So right before we do these, we sometimes give people blood products and albumin bolus with a fluid challenge. We'll make sure that we're taking care of their volume and keeping the bucket pretty full for us to be able to make these holes. If not, the patient can ultimately die. Mark, we all want your cookie. You sharing cookies? It's all right. It's all right. Your picture's right next to mine up here, so I saw you first. So Mark's going to send us all cookies. We expect chip cookie delivery any minute, man.
On top of everything else he does.
Okay. All right. Sounds good. So I showed you that video clip. Let's talk a little bit about the risk that happens if you burn down your whole torso. So one of the other problems is that you can't, your intestines are not going to be able to get good circulation. You can actually cut off the blood tissue or the blood circulation to your vena cava and get necrotizing bowel. This is what necrotic bowel looks like. It's very purple and it should be very pink and bright, and it looks very dark and necrotic. And ultimately, this leads to most of the bowel resection having to happen and can ultimately lead to a significant death. And it's complicated. You do not want necrotic bowel. So we use a device that connects to a Foley catheter that measures the pressure management. So we get your bladder pressure. Your bladder is very soft and pliable. And when it's pushed against with pressure, you don't have much urine output. So decreased tidal volume on your ventilator, decreased urine output, increased heart rate, low blood pressure, a lot of different factors go into this. Sometimes we have to do a release of someone's abdomen, and I'll show you what a picture of that looks like here in a little bit as well. This is an example of why it's important. Your skin serves a purpose of protection, sensation, and temperature regulation. And when you burn it, you no longer can do that. So we have to keep people very warm. Lots of you are probably familiar with the bear hugger device. We don't use bear huggers in the burn unit because they blow air. If my patient is very wet and I'm blowing air across you, what happens? You become more hypermetabolic and you're going to shiver more, and that makes you more hypermetabolic, and that's not a good thing. So I provide a K-thermia machine. I use a lot of wet heat, so I'll heat the patient this way. If they have too much of a fever, you can cool them down with this blanket as well. But usually within the first little bit of period of time, we're going to cover them with plastic, and then we're going to cover them with, we're going to put the heat inside, cover them with plastic, and try to make them as humid as possible. Again, you don't have the ability to regulate your temperature anymore. Important for us to keep you warm. Digestive is a huge issue as well. These are major challenges for all patients in the burn center. Anyone want to take a guess at how many calories you burn in a day with a 20% burn? Laying in bed. You got a guess for me?
1,500.
Try again. Double it, Mark.
3,000.
All right, so 3,000 calories a day doing nothing but laying in your bed trying to heal your burn wounds. That kind of demonstrates about a metabolic rate that you have. You can see here your basal metabolic rate is 2 to 3 times that of normal. Besides being the manager of the burn center, I also manage our feeding tube team here at the University of Utah Hospital. We use this machine called a CoreTrack device. It has a little GPS at the end of a guide wire that allows us to see if you follow this down. It goes all the way into the stomach, makes the turn of the stomach, and then goes post pyloric right here and ends up in the small bowel, which is where you want to be able to feed patients. So we use that. I ended up being the manager of this team after bringing this device in. Burn patients need a lot of feeding tubes. We kind of developed our expertise at that. So be careful what you ask for, I guess. But this is a closer up image of what that looks like. And we, again, it requires my staff not to have to get an x-ray of the patient, decrease the amount of radiation exposure for patients, and you can know exactly where you are very well with this device. So highly recommend it. And I don't have any disclosures with that. I don't make money from them. So indirect telemetry is something that we measure to kind of look at your oxygen exchange, and it helps us to calculate how much consumption. Are there any marathon runners in the room? Wouldn't you love to know how much? I know Mark's like, no, I don't marathon run. I don't either, as you eat your cookie. I'll just relentlessly tease you about that for a little bit. So, but one of the things about it is that being able to calculate how much calorie expenditure you have is a very important thing in your ability to know how many calories you need. So, Mark, just because you're next to me and I keep picking on you, how many calories do you need a day?
About 2,000.
So, Kylie, how many calories do you think you need a day?
1,800.
Why do you need less than Mark?
I'm little.
Okay. So how much, and the example of that is also fluid. Like, I'm a pretty big guy. You guys can't see because I'm not standing in front of you. But as far as like my fluid requirement, like I need 2 to 3 of these a day just to feel like I've had enough, right? Like, this is a liter bottle. I need 2 to 3 liters of fluid a day just to keep up with it, right? And then you think about calorie expenditure and how many calories you need. Healthy people, you need usually between 1,500 to 1,800. Mark says he needs 2,000, right? I mean, everybody's a little different on what their requirements are to feel like they finally hit where they need to be with their measurement. But it's important for us to be able to do this for burn patients. It's important for us to be able to have a good calculation so that we can give them the feedings that they need. If you don't have good nutrition, you can't heal a wound. So kind of the principles of good wound healing: circulation, calories, because you're going to burn them trying to get better, right? And keeping it free of infection. Those are the three big things for wound management. Okay.
So basically, like your burn patients are just like a math problem.
Say that again.
So basically, are your burn patients pretty much just a math problem, and you're just trying to like make it all even?
That's why it's important for you guys to have this lecture today, is for you to really understand burn patients kind of tap into all the different types of care that you guys are learning about, right? You can learn about calorie needs, you can learn about damage to your tissue, you can learn about circulation, hypovolemic shock, wound sepsis from infection. It really does kind of cover the whole gamut, and that's why you're instructors and why I feel so passionate about sharing this with you. My intent is not to make you all burn nurses, although if you want to be a burn nurse in the future, I love that idea. But it's also, it's one of the most dynamic types of patients from such a large, different scale, holistic view. It kind of just hits everything. So you're right, Kylie, everything's just a bit of a mess.
Oh, I said a math, not a mess.
Okay, yeah.
Like a math problem.
I mean, just a mess. I know you didn't say math, but like, yeah, there's a lot of math and there's a lot of things you have to figure out for these patients. They're complicated. Okay. All right. So what's going on with this urine? Yikes. Is that normal?
No.
If you have dark urine like this, what's that usually mean?
Problem with your kidneys.
Severe dehydration.
So it could be severe dehydration. So you mean, or really what we call hypovolemic shock in the ICU world. Okay. Definitely a possibility. What else?
Could it be like rhabdomyolysis kind of thing where you got massive cell death and like the contents are released?
Yes. What kind of a patient have we talked about so far, Braden, that would make you think that? Who in the burn world might have that worse?
So like 3rd-degree burns, large area of it.
Thickness.
Or electrical. Okay, so when I talked about electrical, if I burn my tissues inside, your body, your muscles release myoglobin. And when they release myoglobin, it kind of looks like this in the urine. Okay, it's very difficult for your kidneys to process it, so that's why you need double the fluid rate. So this is an example of rhabdomyolysis. This is an example of possible myoglobin. This is a result of, again, dehydration or your kidney's inability to process what's coming to it. Okay, it could be blood, but most of the time, like you can see that down here in the tube, it actually doesn't look like blood. It kind of looks like it kind of looks like a port wine, you can almost see through it. But it's definitely not blood, usually. So something for you to consider and kind of look at. Again, what we're talking about is hemoglobinuria or myoglobinuria. And again, rhabdomyolysis can come from that. If you guys don't know what that fancy word is, I'll give you some time to look it up. I don't have a presentation in here on rhabdo today, but basically rhabdomyolysis is the breakdown of your tissues inside, and it comes from some type of injury. A lot of people develop rhabdomyolysis after being in earthquakes when rubble falls. So third world countries like Nepal, Turkey, massive earthquakes, they will have thousands and thousands of people die 2 weeks later of rhabdomyolysis from the amount of rubble that fell on them, and they have some type of internal damage with their muscles and ultimately leads to rhabdomyolysis and death. Not a good thing. So renal failure is a big issue. We have to manage those sometimes with patients here in the burn center with a dialysis machine. We do bedside dialysis or CRRT, and I'm sure you guys probably haven't learned a whole lot about it, but this is basically nurse-driven at the bedside dialysis to help you filter things out. So it's something we do here in the burn center at different time periods. Specialized pediatric care, we talked a little about the types of injuries that happen when it comes to kids, and some of the things that are unique here to our burn center is kind of the challenges of that. Your primary and your secondary assessment of your patients are very different. Their airways are very different. IV management's different. The amount of input and output's very different. If you go back to our calculation on fluid management, now you have a pediatric patient, and instead of weighing 100 kgs, they weigh 10 kgs. You can see how that changes your fluid requirement very dramatically, and the importance of understanding how fragile that is. Little kids are not going to need 20,000 mils of fluid, but they're going to need the equivalent based off of their weight. Okay, so very complicated for us, and pediatric dosages are very scary, and there's nothing more scary. I've been all over lots of different ICUs. There is no type of patient more scary to take care of than an intubated small child with a burn injury. It kind of changes your whole sphincter tone and your delivery of your care very dramatically. So very complicated to care for. This is an example of a very complicated pediatric case. I know these slides are not always easy to show, but I like to show you what the day-to-day operations in the burn center look like. This is a child who's a pediatric patient with a trach, had a massive scald injury. These are skin grafts all over his legs and his torso, and you can see where that blood is where his donor site was, where we had to take the skin. This is a very catastrophic injury and hard to recover. This little boy's named Zach, and I want you to kind of think about this picture. We're going to talk about Zach a little bit later when we talk about the recovery of burn injury and the challenges that come with it. So, what can you do to prevent something like this from happening to people? Well, you can educate about hot water. And even nurses are going to end up working in a well baby nursery with babies. Are you going to spend some time teaching new parents about the dangers of their home? How many of you have babies in your home right now? How many of you know elderly people in your home? You take care of your grandparents. How many of you know someone with seizure disorder or MS? Any type of medical issue out there, most people's water heaters are running around 140 degrees. It will give you a third-degree burn in about 5 seconds. I ask you, if you have people like that in your home today, you have small children, go turn your water heater down. There's a simple knob. You can adjust it down to the lower. Most people do not like to do that because they don't like to wait for hot water. 124-degree water is still significantly hot. The hottest a hot tub usually gets when you're baking in those and you feel like you're dying is 106 degrees. That's their legal range that you can get them to. So anything around 124 degrees in the low setting on your hot water heater is more than enough. It's a huge educational issue across our communities. We would see a dramatic decrease in hot water scalds of children here in our center, so I always try to emphasize this. Do yourself a favor as a nurse and realize that education is a huge component of you becoming a nurse, and start thinking about how you can provide that types of education out to the community. If you don't know how to do it, you can YouTube it, a simple video. We publish a lot of different educational stuff all year long on our Facebook page. So if you have a Facebook, I encourage you to follow the UView Burn Center on our Facebook account and share our postings when we put them up there to try to help with community engagement. Get a lot of engagement that way, and we usually try to chase this. It would be my goal not to have to be an operation. I love doing burn care, but I also know that 75% of all the burn injuries we take care of are preventable. So help us out there as much as you can. These are the unfortunate sides of burn care. This actually is a bathtub scalding. One of the things I want you to take note of is it's very different than everything else I've shown you. This line right here is called a line of demarcation. This line across the child's back, if you were laying in hot water, what would you do?
I'd move.
You'd be jumping, moving, doing everything you could as fast as you could to get out of the bathtub. A line of demarcation typically means that you were held against your will and that you were not able to see it. The other thing that happens is on the buttocks area right here, there's usually more intact skin because it makes contact with the bottom of the bathtub and it's cooler. So they're forcing the child down in there. We see this happen when a child pees their pants or has an accident. We see people that punish their kids because of that. They run scalding water and they dunk the child in it. The other thing that you see typically is that you can see the foot is burned. Both feet are usually burned, but the knees are not, because the child bends their knees, their feet are in the water, and their butt is in the water. And you think about a child, when you pick them up, their legs immediately lift up, a baby. This is unfortunately something for you to consider. Non-accidental trauma is unfortunately something that all of you are going to see at some point in your medical career, whether or not you end up in the burn center or not. Please remember your professional responsibility to notify Division of Family Services or the police department regarding any type of non-accidental trauma. I do see non-accidental traumas in adults as well, but primarily in children. And we see usually around 2% of all of our patients each year. So that's about 20 patients a year have some type of non-accidental trauma for us. We unfortunately have a significant relationship with Primary Children's team called the Safe and Healthy Families team, as well as Division of Family Services for these types of situations. It's a heartbreaker. It's hard to see. It's a tough one for sure. So pay attention to it. The stories usually change. You'll get, if you work in an ER and you have someone come in, the story keeps changing. parents are stressed. They know that they burned their child. There'll usually be a delay in seeking medical attention or care, and then the story keeps changing as you find out more. You asked what happened. The doctor asked what happened. It keeps changing and evolving and getting more complicated, and it just doesn't add up. Follow your gut. Make sure you're taking care of yourself, and make sure that you know, everybody's innocent until proven guilty, so it's a hard situation to be in as a medical provider for sure. I want to talk a little bit about electrical injury now and dive into this. What's different about this picture? It's different than everything else I've shown you. What's different about it? Jeannie just asked if that baby had a diaper on at the time of getting burned. No, the diaper was not on. The child was dunked without a diaper. Yeah, and Amy, you just commented you can see the veins. Why would you might be able to see the vessels? Why is this different than the other burn?
Because the electricity goes through the veins and burns as it moves up.
Yeah, it doesn't go through your veins, but it goes through your body from the inside out. And when that much heat, it's usually indicative of a massive amount of heat. I know that because a couple of the fingers are blown off. You see how the fingers are missing? So these fingers are missing right here. They've been blown off entirely. And that tells you that the amount of heat that was coming through there actually cauterized the blood vessels right where they were and exploded out the fingers. So that's a ton of heat. This is probably somewhere higher than 9,000 volts of electrical current. That's when we see these types of catastrophic injuries. This ultimately led to significant amputation of both extremities. This is also an example of an electrical worker who was told a box was off that he went to work on. This was on admission, and this is after debridement of those tissues in the surgical room. The amount of tissue damage underneath the surface of the skin compared to this is very, very different. And ultimately, it can lead to an extensive type of breakdown like this. You can see all the tendons are exposed here. The blood vessels are exposed. The functionality of this hand is most likely lost, and a lot of times these lead to amputations. Having exposed tendon like this is not a good situation. This is also an electrical injury. This is a gentleman who is on the back of a truck where the boom made contact with a power line in a windstorm. This is an example of showing you again, this is probably an exit wound where the electrical current went out. Could be an entrance wound. It's hard for us to know. But the flash is kind of eliminating this, but all this tissue is very hard. It's very third degree, and this gentleman lost all of his toes up through to his big toe, from here all the way up to his foot here. Okay. Point of contact, this is some of that white cream on there again that we use on burn injuries. You can see this as a point of contact, and if you were to touch this, it would feel like kind of chewed hard rawhide that your dog leaves behind. It's very hard, no feeling, and significant injury for sure. This is the gentleman's other hand. I have not shown you anywhere except charring, except for that 4th degree car fire. Charring again indicates significant amount of time on fire or large amount of heat very quickly. So this also, you can see the color of the gentleman's hand is very dusky. This is the other hand from the same gentleman, one with this hand and the other one with the vein. So electrical current's nothing to mess with, that's for sure.
One of the guys.
There's an up close of that one again, just so you can get an idea what it looks like. No feeling, completely dead, no circulation, completely destroyed. This is a gentleman who was wearing steel-toed boots, whose forklift came in contact with an electrical panel in a warehouse when he ran into it. He jumped out of the forklift and then realized he left the forklift running and went back to the forklift, and when he touched it, made contact with the electrical current of the forklift, and this is what the damage did with the steel-toed boots. Steel-toed boots are great unless you're coming in contact with electrical current. So this is unfortunately some of the damage there. Lost his foot back to his heel, and a complicated burn injury for sure. My favorite slide, don't stand underneath scaffolding with hot tar above you. So a bucket pulled over on this gentleman and poured over his head. One of the good things about tar is that it usually melts around 120 degrees to 125 degrees, which is why it always sticks to your feet as you walk across the road on a hot summer day here in Utah. So he did not suffer a catastrophic burn injury, but very quickly had this tar all over him. The best thing to do if you have someone with tar or some type of chemical like this is to cool it very rapidly, pour cold water on it, make it as hard as you possibly can by pouring the cold water on there, and then we can use an adhesive remover to be able to break that down. This person actually went home the next day. You can see they had a pretty a nose that was burned. They maintained their airway throughout. We were able to get it all off and be able to return this gentleman home the next day. So kind of crazy world of tar, asphalt, and melted plastic. So we sometimes, people say melted plastic. Sometimes people heat up microwave ovens and they'll go to touch the plastic and it'll wrap it around your finger, something like that. So cool it, then remove it as best you can. Definitely things to consider. So I mentioned earlier at the beginning of the lecture that we had a lot of different things to talk about today. I'd like to kind of highlight some of the other types of areas that we do take care of. We take care of frostbite injury, necrotizing fasciitis, purpura fulminans, TENS, which stands for toxic epithelial necrosis syndrome, or Stevens-Johnson syndrome. We have traumatic degloving injuries. We take care of things called pemphigus vulgaris, calciphylaxis, and a lot of other types of non-healing wounds. I've highlighted a couple here just so you guys get a sense of kind of what they look like. Necrotizing fasciitis is part of that 30% of our patients that we care of, or what we call soft tissue injury. It's very rare but serious, most commonly caused by group A strep, and gets to be very complicated for that. In many cases, other type of trauma event has happened. They've probably bled in that area. They've had a puncture from a nail or something like that, and they've ended up having a significant injury. If it happens in the genital area, it's called Fournier's gangrene, but it's still necrotizing fasciitis. It's just a different name of it when it's in the groin area. You can have up to about a 50% mortality rate and a lot of sepsis. This is an example of what that can look like. You have some type of puncture wound. It starts to get infected, and all of a sudden you realize that you're getting necrosis. That strep will carry right through the muscle layers along the fascia and can lead to severe amputation. You also often get significant sepsis within a 24-hour period of time. These people need to get to the hospital immediately. They need to have surgical intervention immediately, and they need to have antibiotic therapy immediately. So this is all dead. It's going to have to be cut out. I'm going to show you guys some dramatic pictures here of necrotizing fasciitis. So this is an example. Looks a little bit like what we call a shark bite. I have to tease all the student nurses because occasionally they'll see a wound and someone will be like, what happened? Like, oh, it was a Great Salt Lake shark bite. So there's no sharks in the Great Salt Lake, but this is an example of what a shark bite would really look like. Is it's taken out huge sections of skin, and all of this has been debrided. We've removed all the dead tissue, and what you really want is this person's going to be with us in some type of wound vac. This little area right down here is called you're starting to see what's called granulation tissue, and it's very bright pink and red. We want this whole thing to look like that before we try to put a skin graft on it. So we're going to cut away the dead tissue. We're going to do a lot of aggressive wound care. If we get a wound vac on it, we'll wound vac it for a while, and we'll take great care of it that way to be able to manage it. So it begins with surgery, a lot of antibiotics, fluid resuscitation. A lot of times these folks need vasopressors like Levophed. They need a lot of wound care support, nutrition support, and a lot of physical therapy to kind of get back to normal. All right. When it comes to basic wound care, a lot of people ask me what kind of things we do for our patients to be able to care for them as best as possible. So we do some basic wound care treatments, kind of the basic concept of wound care. And you already guys know, you guys are the experts of your family now because you're in nursing school, right? Your phone rings all the time, and people want to know how to take care of different things and what's going on. So prevent those infections with daily hygiene. Washing the wound is really important. So I always encourage someone to bathe. So many people are told, oh, don't wash it. The best thing you can do is move it and wash it and clean it with soap and water. It's daily hygiene, promote and assess the wound, make sure it's getting good circulation. Remember, I said the three components. You don't want to have an infection. You want good circulation, so you got to clean it. You want great circulation by moving it and getting good fluid management and walking on it or moving it around. And you ultimately want to make sure that it's getting debrided and cared for and assessed well. Preventing those pain control issues, determining the need for surgical interventions. We use a lot of different wound care supplies. We typically do wound care twice a day here in the Burn Center. As wounds start to close up, we go to Q day, and we do a lot of what's called hydrotherapy. So we put people on the shower table back in our wound care procedure area, or we take them into a shower and bathe them that way. These are some of the breakdown of different meds that we use. This is Silvadene. It's easy to use. It looks like this. We kind of make it like cake, like icing on a cake. Cover the worm wound, and then we cover them with gauze, wrap them, and make them walk. I told you also I have a lot of stuff to cover today, so it seems like I'm picking up the pace. I'm 70 slides into 115 slides, so that's why I'm moving along here, you guys. When it comes to grafting, this is the machine that we actually use to do skin grafting. It's called a dermatome, and you can see it has different guards for different sections of skin. It takes a kind of a cut through down into your dermal layer, then that's called a skin graft. We'll pick that up and we can move the skin. So types of grafts are autograft, meaning it came from yourself, homograft, which means it comes from a cadaver and that's only temporary, or you can do xenograft, which means it comes from some type of animal. That's usually pig skin if we have to do that. The pig skin's been used for a very long period of time. This is usually the period in the lecture where someone that was on Facebook within the last year sees posts all the time about using fish skin for burn management. It's called tilapia skin. I usually get a question every lecture I give. The United States does not need to use tilapia fish skin in order to heal burn injuries. That's something a lot of third world countries do. The United States has a lot of skin banks where people donate their tissue after death, and we're able to provide homograft that way. It's just a temporary covering to help your body try to get better from its burn injury. So that's where the idea came from now. Different types of grafts like I talked about. Again, autograft is from you. It's permanent. It comes from you, moved from a location to another location. Homograft, again, comes from cadavers. And xenograft, again, comes from different types of animals. This is what the dermatome looks like when it's cutting off the skin. This would be us cutting off dead tissue. This is what it kind of looks like, a little bit of a cheese grater. And this is what it looks like after we harvest the skin for a donor site. You can see this looks like a lot of blood loss. It's actually not very much blood loss. We actually take a large spinal needle and with epinephrine in it with lactated ringers, and we inject it underneath the surface of the skin before to clamp down the blood vessels so that we have less blood loss when we take off your skin. So kind of crazy. You can see it's kind of a second degree burn now that we've given you. That's why it's important to understand you have close to 100% body involvement by the time someone leaves the burn center. We take that skin graft, we put it on a plastic board that you can see kind of has different lines on it, and then we run it through a machine called a mesher. See if I can get to it here. My slides are bogged down all of a sudden. I got the circle of death there. Hold on a second. Hello, slides. You guys can still hear me, right? Okay. See if the computer will catch up here real quick. Okay, there we go. This is I don't have a video for this, but this is the machine called a mesher. We basically crank the skin through there, and it ends up punching little holes in it. The reason I punch little holes in it is I can take a piece of skin this much that I harvested, punch holes in it, and make it this wide. Okay, I can cover more surface area by punching holes in the skin. Cosmetically, it's not as appealing, but it's the most important way. We mesh almost most of our grafts unless it's going to be on the face or the hands, and then we do a sheet graft. So different types of grafts require us to do different types of things. Anywhere on your extremities, your back, your chest, or your arms, we're going to punch holes in it and cover you that way. If it's on your face, we're going to leave the skin in a sheet, and it's called a sheet graft. So this is what it looks like to someone that has a graft over here. This is a burn that was allowed to heal and never skin grafted. You can see the difference of scarring and kind of the challenges. This is an example of a full thickness sheet graft. This is a child who grabbed hold of a curling iron and needed to have surgery on this. So one of the things that's really great about kids is that we can actually take a section of skin from their groin. They usually have a lot of little curled up little rolls of skin in their groin area. We can take a full thickness piece of skin, do a primary closure and close it without them ever having a donor site, and put in a full thickness skin graft here. You can see us suturing that into place, and it does a really great job of cosmetically looking a lot better down the line. This is an example of a sheet graft to a hand, so we did not punch holes in it. Has seams on it always, but overall cosmetically, this is about 5 weeks later. Pretty impressive. So skin grafting works. It's very effective. You can see that sheet graft line right here. This line that's right there, you can see right here. But overall, quality is looking pretty good. And overall, we've gotten good wound closure, been able to manage it. Movement's going to continue to be a challenge. We do a lot of aggressive physical therapy and occupational therapy to try to help people get back to a more normal way of living. This is a case scenario I want to share with you also. This is a little girl in a house fire, candle in her bedroom that caught the room on fire, and she ended up getting burned significantly. This is her face. She has a cutaneous injury of a 3rd-degree burn over her entire face. This is a sheet grafting her whole face. This is post-operatively. This is about 2 years later when she was a little girl at the age of 2. This is at the age of 18. She's now 26, and she's a nurse in Montana and is living her best life. And I think overall the outcome of that's pretty amazing. I think she's done quite well. Does it look perfect? No, but she continues to manage that. We do a lot of laser management of scar injuries now. So the same type of laser that you use for laser hair removal is used to manage burn scars as well. And we can kind of break up and make them a little bit more soft, and we can also make them a little less red. So we'll do a lot of work that way for our burn patients to be able to try to cosmetically return to as close as possible. Burn scarring and pressure options are a huge issue for our patients. A lot of challenges. ABSS stands for anti-burn scar support. So when you see a burn patient in the community and they're wearing some type of face shield like this, that is to put pressure against the scar. Takes about 1.5 to 2 years for a scar to fully mature. If you think about one of your scars in your body, you think, yeah, that's about right. It seemed like it took quite a while. They go off from kind of very hard to getting more soft and subtle. There's a lot of different things you can do for scar management in the burn center. We're experts at it. We customize these pressure garments, which again stands for advanced or anti-burn scar support. And the idea is a scar wants to grow up like this, and we're putting resistive pressure against it. You wear those for about 23.5 hours a day for about 2 years. If you're a child that's burned when you're like the age of like 2 and you fell into a campfire, you're going to need to wear these garments for the majority of your life because the scars will not stretch and move. You have to have new surgeries pretty much every 2 years as you grow and have a new skin graft placed in. We'll cut the skin graft and then we'll put a new skin graft in, cut the skin graft, put a new skin graft in. So if you have a burn injury that's on the top of your foot, as an example, you start to grow, you go from a size 3 foot, you start to expand, and you're growing to a size 11 foot. That's a major issue. You're going to need a lot of surgical intervention to be able to help you with that. So getting burned as a child has a lot of life consequences until you stop the growing cycle. But you pretty much live in the burn center, and our summertime is filled with kids that are needing surgical intervention so that they don't miss school. These are some other types of pressure management. We use a lot of vet wrap, or what you might call Coban, to start shaping the hands or different extremities of different things. This is called an isotoner glove. If there's anybody old in the room who knows who Dan Marino is, he used to sell isotoner gloves as kind of his gimmick of, he loved isotoner gloves to protect his hands in the winter. They actually do a nice job of being pretty custom fit and movable, and they help to shape the hand as well. So we use isotoner gloves to be able to do that and help people with those options. The most common post-burn problems are all of these. You see a lot of scarring, you get a lot of joint contracture. Itching is a huge issue for our patients. You get a lot of change in the way the skin looks, but probably the biggest thing I want to focus on the most here is PTSD. Patients who are injured with a burn injury suffer a lot of catastrophic psychological management issues. And when I told you at the beginning of this lecture today that our burn center specializes in holistic care, I want to highlight that a little bit more for you. Some of the most common burn patients, if I was to ask you, are these. It's very hard to think about the world's most famous burn patient, but most of us unfortunately think about Freddy Krueger. He was burned and he has to kill people because he was burned. The Phantom of the Opera, Mel Gibson, The Man Without a Face, and most recently the movies of Deadpool all mimic that of a burn survivor doing crazy things or having to wear a protective suit like Deadpool does to not show off all of their burn injuries to the general public. That's kind of how society and the world kind of thinks about burn patients. We try to work really hard against that as we take care of people here. If you want to see a really great movie kind of explains kind of the pressure of burn injury, Mel Gibson, The Man Without a Face is an outstanding movie for that, to demonstrate kind of the impact. Only shops at, gets burned in a car accident, wife dies, he survives, has a lot of guilt, was a school teacher, is not allowed to return to school because of how he might make the kids feel, is only allowed to shop at the grocery store at night because he might scare people. This is him, and this is a clip from that movie, him scaring this kid, and they go on to develop a significant relationship and kind of just highlights the impact that they have. All of that changed for the world on 9/11. We just had the anniversary recently of it, unfortunately. But the reason I highlight that here is that the only people to survive the World Trade Center disaster and the Pentagon were burned. There were 18 total burn survivors between both places, between the Washington, D.C. burn center and the New York burn center. We sent nurses from our burn center there to take care of it. An example of the first plane hitting, there was a woman at the bottom waiting for the elevator, and it came pouring out with jet fuel that was on fire through the whole lobby, gave her an 80% cutaneous injury just standing at the elevator door waiting for the elevator to open. So significant injuries, big life impact. And this was right after 9/11, about a month after it, and the Wall Street Journal said there's no mirrors in burn units. And I think my statement for putting that here is that's a bunch of crap. If any of you are burned today, the first thing that you want to do is look at your injury. You want to know how you look. We are all very invested. All you have to do is look across one of our Instagram pages to see our selfies. We love looking at ourselves, and we love to know how the world views us. And society puts a lot of pressure on. When you're burned, it's a major, major deal to your psyche and does create a lot of post-traumatic stress for a lot of people. One of the things that we do for that is we offer an enormous amount of support services. So we offer patient and family housing for families to be able to support their loved ones here. During COVID, that's been a bit of a nightmare because visitation's not been an option. My centers hurts from that very much because it takes an entire family unit and an entire hospital unit to get people through their course of stay. We offer a lot of different things you can look through this, and we even offer support groups in Idaho in addition to here in Utah. But one of the things I didn't tell you at the beginning of my presentation is I've been here in the Burn Center for 30 years. I started here when I was 19. I'm now 49. I fell in love with burn care. One of the things that kept me in love and passionate about burn care was being able to give back to survivors. So I was one of the people who helped create this program. We call it Burn Camp. We now have 5 different programs for our burn survivors. This is a picture of Zach that I showed you earlier laying in that crib. This is him as he's progressing through his injuries. And I'll show you some pictures of Zach as we kind of go along here. So 5 age-specific programs. They're challenge-based. We have to do all the fundraising every year on our own. Volunteer-supported, no cost to survivor. And our programs have become an international leader of burn camp programming. We're recognized as providing some of the best programming across the world. We offer preschool camp for 4 and 5-year-olds, which is a day camp. These are some of our little preschoolers coming to day camp at Mill Creek Canyon here in Salt Lake. They come on the last day of Camp Nanama, which is ages 6 to 12, which is a 5-day, 4-night camp. We're geared towards developing skills and managing their burn injuries. We do a lot of role playing. You would be shocked at how many people come up to a burn survivor in the grocery store and will say something like, "Oh my God, you poor, poor thing, what happened to you?" It's crazy to watch the general public impact people. So we'll do a lot of role playing. We'll teach a young survivor to have a rehearsed response, to be like, "Oh, well, thank you for noticing I'm burned. I'm doing great now. Have a great day. Thank you." Right? But teaching some skills like that's pretty important to teaching them. This is a program is 100% firefighter funded by firefighters throughout the state. You may see fundraising activities online and things like that. These are some of our kids doing camp, climbing a rock wall. You go from being Zach in that hospital bed in that crib looking like you can't do anything to climbing a rock wall. That's pretty amazing. This is a therapy dog. You can't tell. This little girl looks like any other normal girl. The back whole side of her head is missing her hair, and she has a gigantic skin graft on it that she has to walk around with. Okay. Thanks, Mark. We appreciate that. Maybe that's why you look familiar. Very familiar to me. So, our programs are pretty important that way. This is actually a firefighter with Salt Lake City Fire and one of our burn survivors that they rescued. I think that's a pretty powerful statement for a firefighter to come to camp and end up taking care of a child that they rescued in a fire. It's kind of full circle. It's good for the survivors. It's good for the firefighters. It's good for the nurses to be able to see people that they care for. We offer a 6-day river rafting trip for our teenagers. This kid right here is now 25, married, and he is one of the only documented hemophiliacs to ever survive a burn injury. 60% burn with hemophilia was one of the most complicated cases. His picture's right behind me right there, as you can see in my office. I've got his picture up right there. It's just a pretty important moment for me to remember. This little kid achieved a lot and has gone on. We go down Desolation Canyon on the Green River, get to see a lot of petroglyphs. Nighttime provides a lot of opportunity. People are sometimes shocked we have a campfire. You get burned in a campfire, one of the best things you can do is start trying to be normal again. You get in a car accident, you got to get back in your car tomorrow. Right? You got to figure out how to drive. So we get people back in that same thing. We promote the fire as a safety. We talk a lot about safety. We make sure we're watching out for each other. But we go around this circle and we talk a lot about the complications of what it's like to be a teenager and then the complications of what it's like to be a burn injury. So not a very easy situation. We have a young adult program. This is young adults learning how to cook. A lot of burn injured patients come from lower socioeconomic status situations across the nation. And that seems to be a pretty important statement these days. The differentiation between systems that are supportive and systems that are not is pretty catastrophic out there. This instructor used to teach the noon cooking show. She's a friend of mine on Channel 2 News, and all she's doing here is making some eggs. And this survivor said to her, "I didn't know you could put pepper on your eggs while you were cooking them." So it's very basic types of things that we're trying to teach. We also go through a lot of life skills. We have them do interviewing skills. They may not have a lot of confidence to walk into an interview, and teaching someone that has a large scar how to take care of themselves with these types of injuries, nothing but a huge win for us to be able to give them those skills. So teach them how to apply for jobs, how to apply for scholarships, things like that. We also offer an adult program. This is an adult program. This is my friend Leonard, who's unfortunately passed away not too long ago from a pneumonia, but he's done quite well. This was him and his family at Adult Burn Camp. This is our survivors running Cataract Canyon and getting to have a wonderful time together. This may look just like a rapid or a raft shot from a river trip to you. To me, this is actually support group. All the boats are tied together, and we're doing support group as we float down the river. They're all looking towards a survivor who's over here speaking at the time and telling everyone a little bit about their experience of a burn injury. And there's nothing like a more bonding place. This is right below Dead Horse Point down in Moab area. Nothing like floating there. This is one of my most outstanding survivors is named Sam Matagi. If you want to see the most inspirational YouTube videos you've ever seen, you might consider YouTubing the No-Handed Bandit. The No-Handed Bandit, he lost his extremities in an electrical accident. He got out of the hospital and he went to YouTube to find videos to help him learn how to live his life as a double amputee. And guess what he found? Nothing. So he's created his own YouTube channel for double amputees and travels the country being an expert lecturer. And this is him playing Frisbee with his double amputees. This boy can work you on a basketball hoop. He has basketball hands attachments, and he plays in the 3-on-3 jazz tournament every year and comes close to winning it, if not winning it every year. So very outstanding pushing from survivors. This is back to Zach. So this is that little boy that was laying in the crib that I showed you. This is him at the archery range. We do an archery program for our survivors, and this is him actually using the sewing. He'd kill me if I had a picture of him with the sewing machine. But he is a teenager that's learning how at camp. We try to give him skills. He's making his own pillowcase and learning how to do some basic sewing. We try to give them a lot of life skills because they just don't have those present in their life. I'm asked often when I lecture what the most memorable moment was of my burn career. And I have to tell you, although I've worked here at the University Hospital for 30 years, it was not here in the University Hospital where I had my most memorable experience. I was lucky enough to travel right here in the smack middle, right above the eye, to the small town of 10 million people in Jining, China. And it's right on the edge of the largest saltwater lake in China. So they kind of consider Salt Lake City to be a sister town. And we were flown there by the Chinese government to help them learn how to provide burn care. This little boy had a pneumonia. We were consulted and told that he was dying, and we were asked to assist. And when we looked at his chest x-ray, he sure enough had pneumonia. But one of our answers for that was like, can he walk? And they all looked at us like we were crazy. They're like, oh, we don't walk our patients. So we were like, well, we're going to walk him. And they're like, no, you can't do that. Well, this is about 15 minutes after them telling us that we couldn't walk him. This is me walking this little boy down the hallway. Okay. His pneumonia cleared, and he was able to survive his injury. And this is him at each of his birthdays since I traveled to China. I get a little picture all the time. You can see the nurses there still wear the little nursing hats. They wanted to know where mine was as a male nurse. I didn't have my little hat. But pretty amazing journey for me to be able to share with you kind of the outcome. They thought this little boy was going to die with a 30% burn injury, and all they needed to do was to help him to heal his wounds, was to establish circulation and to walk him. So don't take for granted what you guys can do here in the power of the United States. There's a lot of things we take for granted in the healthcare world, that of ventilators, Foley catheters, getting people up with physical therapy that a lot of other countries don't have. So if you stick to the basics in your burn or in your nursing world, of ambulatory care, making sure people getting up, get them up and sit them in a chair, make them walk, they get better. Don't hesitate to realize the power that you have to make people better. This is my amazing supportive family that's helped me to be able to be a burn nurse for 30 years. Couldn't have done it without them. I appreciate the time today. Don't forget to follow us on social media, on Twitter or on Facebook, and I'll take any questions from you.
I have a question, and maybe this is a silly question, but when we're talking about burn shock, you said that vasoconstriction increases, but that blood pressure decreases. Wouldn't blood pressure increase if you're vasoconstricting?
If you were not losing fluid, so you've lost all the fluid, so your vascular system's empty. That's why. So you are not wrong, Leslie, when it comes to looking at the actual mechanism, but that's in a normal, healthy person. What you're really talking about is fluid volume, right? These people are hypovolemic; they've lost that fluid.
Got it. Okay, thank you.
Yep. Thank you so much for the opportunity to talk to you guys today. Are there any other questions I can answer for? I got done a little early for you, so sorry you got a little bit of a break. I'm sure you won't mind.
Appreciate it, Brad. We really, really do.
All right. Well, I love giving this lecture. Love teaching about burn care. Don't be shy with me if I have an opening here and you're someone who has some previous experience in burn care, looks interesting to you. The biggest thing I'll tell you is that burn care is intensive care of the critically ill, and it's also intensive care of the rehab patient. All of our patients come in here in the critical phase off the helipad, and they ultimately are here for months and months and months in the rehab phase. So a nurse that works here ends up being an intensive care nurse for adult and pediatric patients. You end up being a rehab nurse for adult and pediatric patients. So I fell in love with caring for people through their whole circle of holistic care. Sometimes that doesn't appeal to everybody, but that's what we do here. So if there's something I can do that way, please don't hesitate to reach out to me as you reach your RN status. I don't hire LPNs here, and you have to be a BSN to be able to be hired at the University of Utah Hospital. Okay? Thank you very much, you guys. Have a great day, okay?
Thanks, you too.
Brad,
Thank you.
Yes.
you guys at 12:30. Yeah, more lecture.
All right, 12:30. Okay.
Here we go. All right.
Thanks, everybody.
Thank you.